preparation and your personal doubts, but we'll take them towards the end of the session, right? So first academics, right? Let's get with the topic at hand, that is NEET PG PYQ series of radiology. I'll try to be very quick because radiology you have already finished, I'm sure, with other subjects, and this is just the revision part. So we'll be very quick with revising radiology important images, and I'll also tell you some new images, some upcoming questions which are important. And then towards the end of this session, I'll take your queries. Okay, right. So thank you, Abhilash. Thank you for asking. I've been down with the viral fever for the past few days, and I'm feeling much better today. Thank you. Yes, the radio is quite easy, I know. Right, so let's just start. Since it's very easy, I'll ask you guys to answer. You guys take the lead, and I'll just keep flipping questions. Okay, right. So quickly, a 16-year-old patient with history of spinal tuberculosis was brought to the emergency with low-grade fever, dull backache, and persistent flexion deformity of the hip joint. Right. So what have you guys marked? Which is the muscle which is involved? Which is the muscle which is involved in this? This is the muscle which is involved, right? And this is the B option. B option is correct. Which muscle is this? This is psoas muscle, right? And what are we mainly focusing on? What is this pathology? This is psoas abscess, right? And psoas abscess happens as a complication of port spine, right? Now, whenever you have a psoas abscess, what do you want to treat? How do you want to treat it? So it depends on the size of the psoas abscess. So if the size is big, you need to drain it. Draining is by a pigtail insertion, which can either be, ultrasound guided or CT guided. Plus, you have to start with ATT. You have to start with ATT. So pretty easy question. Psoas abscess, very, very important. You learn it in ortho as well, a complication of TB. And let's just understand how does TB occur. So this is a typical MRI of port spine, right? So what will happen in a MRI of port spine? You will see number one, destruction. Destruction of what? Spine. Which part of the spine is involved now? Now it affects the paradiscal part most commonly, right? So you will see that the intervertebral discs are spared, right? The intervertebral discs are spared, and the paradiscal part, this is what is involved. So you see here the intervertebral discs, the IV disc, intervertebral discs are spared, and they are involved late in the disease. So when the entire body is dead, is involved, then only the discs get involved, right? So paradiscal involvement with sparing of intervertebral disc is hallmark of TB. And along with that, you get multiple abscesses. Plus, you get abscesses where anterior subligamentous and epidural abscesses. Okay, so you will see abscesses here and here. This is typical of port spine. Again, you see the second image, the vertebra involved, but the disc is spared. The disc is spared. This is typical of port spine. And sometimes what else can you get in the question? You can get a gibbous deformity. Gibbous deformity or kyphosis. That is due to this destruction, there can be this angulation. For example, here you see this angulation. This is a gibbous deformity. So TB you can't miss. You can't miss a TB MRI. And this is a very, very common MCQ, very, very common PYQ that is asked in NEET PG. Now let's move on to the next question. We'll do it very, very quickly, PYQ series, because you want to finish as much as questions as possible. So 12-week-old child, it's an infant, fever, cyanosis, fatigue. So cyanosis जब भी आ गया बच्चे में, we are what thinking either a cardiac or a respiratory cause. Now cyanosis है, fever है, fatigue है, chest x-ray दे रखा है, what is your diagnosis? Right, all of the options are cardiac, so we are thinking of a cardiac cause of cyanosis. Fatafat, what is this appearance called as? This is figure of 8 appearance, right? All of you have answered this correctly. Very, very easy. This is TAPVC, total anomalous pulmonary venous return. Now quickly let's finish the other heart x-rays also. This is your favorite part. All of you know these signs, so I'm not going to waste any much time. The signs and diagnoses are already written. Boot-shaped heart, TOF, box-shaped heart, Epstein anomaly, figure of 8 snowman's heart is supracardiac TAPVC. Now, as a bonus question and as an advanced question, let me give you few more scenarios. All of these are causes of cyanotic congenital heart disease, right? So in question, all of them will be given cyanosis. We'll have cyanosis in the question. That is number one. Number two, what is important is that in TOF and in Epstein anomaly, there is reduced pulmonary blood flow, also known as pulmonary oligemia. That is black lungs. So you will see that the lung fields are black. See that the lung fields are black. There is no pulmonary vasculature. And if the same X-ray, same looking X-ray happens to be with a lot of blood vessels, then you can't mark TOF. TOF ka hallmark is reduced pulmonary blood flow, right? So always and always see the lung fields. I see a lot of students not seeing the lung fields, just looking at the shape of the heart. It's looking like a boot shape. Let me mark TOF. No, you have to confirm with the pulmonary blood flow. In TOF, the pulmonary blood flow is reduced. It's a hallmark because pulmonary stenosis happens in TOF. If the same X-ray happens with the same X-ray happens with increased pulmonary blood flow, the answer is likely TGA. Likely TGA, right? So always and always look at the lung fields. Okay. Now in how do we differentiate TOF versus Epstein anomaly? Both of them have reduced blood flow, but in Epstein anomaly, you have cardiomegaly. And in TOF, you have no cardiomegaly. Heart size is normal. Now you'll ask that why, sir, in TOF you have right ventricle hypertrophy. So remember, cardiomegaly does not mean no chamber enlargement. Cardiomegaly कैसे measure करते थे? CT ratio, cardiothoracic ratio. Cardiothoracic ratio normal होता है TOF में, although there is right ventricle hypertrophy. But in Epstein anomaly, there is cardiomegaly and increase in CT ratio. Right, so this is very, very important thing that you should not forget. Always look at these two things when you are marking TOF as an answer, that there should be no cardiomegaly and the pulmonary blood flow should be less, that is, it should be a black lung. Okay, clear? Yes, okay. All of you know teratogenicity, Epstein anomaly, lithium, all other important lab one liners you already know. Okay, now in TAPVC, again, it's a cause of cyanosis, but here you will see that there is increased pulmonary blood flow, also known as pulmonary plethora, right? So you will see a lot of blood vessels going into the lungs. This is pulmonary blood flow. Now tell me which type of TAPVC has worse prognosis? Which type of TAPVC has worse prognosis? Yes, Preet, for FMG, there will be a separate session. We are running an FMG marathon starting from 6th July. So for FMG, there will be a separate session. Good. So TAPVC worst prognosis is infracardiac type. Infracardiac TAPVC. Chalo. Let's move on to the other important chest X-ray. So again, egg on string appearance is TGA. But again, TGA में how do you confirm it? TGA will have increased pulmonary blood flow. So apart from a narrow pedicle, this narrow pedicle, what else do you have to confirm? You'll have to see these increased blood vessels, right? This confirms that this is a increased pulmonary blood flow and this is not a TOF, this is a TGA. Chalo, fatafat, tell me now what is this? What are these three sets of images showing you? So first of all, this is a barium swallow. And what is this showing you? This, it is showing you a posterior indentation on the upper esophagus. Very important, upper esophagus and posterior indentation. Now this type of indentation is eccentric. Eccentric meaning बाहर से दबाया है किसी ने. Eccentric indentation. And why am I saying it is eccentric indentation? Because the angle is obtuse. It means there is an eccentric indentation. And to support this, what have I given you? I have given you a CT. Now this is a recent question which has been asked. What is this abnormal vessel which has been highlighted by these arrows? What is this? This is URSA. This is aberrant. The diagnosis is dysphagia lusoria. And the cause is aberrant right subclavian artery. URSA. Right, so this is a previous year question, has been asked very recently and very important for you to know, because now more and more incidental findings are being picked up, and this is a potential question. Now this was the image which was asked to you, similar looking image, but what they can now ask you is this type of an image. Right, now what is this image showing you? This is the aortic arch, and you have great vessels coming out from it. So this is the brachiocephalic trunk giving rise to common carotid arteries. Then you have the left subclavian, and then behind the left subclavian, this is your right subclavian artery. Right, so it is coming last. This is how an URSA looks like on VRT image. This type of image is known as VRT image, volume rendered technique. Okay, this is not double aortic arch. This is the normal aortic arch with URSA. Now, double aortic arch, I'll show you various arch variations, and arch variants are important because now they have asked you URSA, they can ask you other arch variants also. Now, the most common arch variant is something known as bovine arch. Now, what is a bovine arch? Sorry, forgive me for my bad throat. I'm recovering from a viral fever. So I'll try to be as crisp and as clear as possible, but just bear with me for a while, right? Now, in a bovine arch, this type of arch is seen in bovines like buffaloes, cows, axes, right? So like us, they don't have three great vessels. What are our three great vessels? Brachiocephalic trunk, left common carotid, and left subclavian, right? But in them, they have only two branches from the aortic arch. What are these two branches? This is a common trunk which gives rise to this brachiocephalic trunk. So this is the brachiocephalic trunk which divides into right common carotid and right subclavian artery. And from this common trunk, you have the left common carotid artery also. And then there is a separate origin of the left subclavian. So this type of origin is known as a bovine arch, wherein they have only two branches from the aortic arch, two great vessels, right? This is the bovine arch, most common variant. Now this is how a double aortic arch looks like. Now a double aortic arch on CT scan, because you will be given a CT scan only, will have an inverted V appearance. It has an inverted V appearance, a double aortic arch. So from the right side arch, the right side vessels come off, namely the right subclavian artery and the right common carotid artery. And from the left side arch, the left great vessels come out, right? Meaning the left common carotid and the left subclavian. So this is the double aortic arch. So on CT, how will it look like? It will have an inverted V appearance. And then finally, we have a very interesting variant in which the aortic arch is on the right hand side, right? But there is an aberrant left subclavian artery. पहले में क्या था? Aberrant right subclavian artery थी कि normal हमारी left sided aortic arch होती है और right subclavian aberrant होती है. But यहाँ पर क्या होता है कि right aortic arch होती है but the left subclavian is aberrant. So it shows this V sign. It shows this V sign. So V sign is right aortic arch with aberrant left subclavian. Inverted V is double aortic arch. Is double aortic arch. ठीक है? Any problem in this? ठीक है? थोड़ा confusing. It's a little confusing. So first tell me, have you guys understood this or should I repeat? Okay. Chalo. Next question. Sir. Understood? So next question. Thank you, Arpit. Patient presents with abdominal pain and distension. X-ray was taken. It shows dilated bowel loops. Identify the segment involved. So we know that these are small bowel loops, right? Why small bowel loops? Because they are in the center. They are in the center of abdomen. So यहाँ लिखते हैं wait. And they have complete septate. राइट सो कौन सा है जजनम है कि इलियम है सो अपर एब्डोमेन रिमेंबर अपर एब्डोमेन में जजनम होता है एंड लोअर एब्डोमेन में इलियम होगा सो इलियम आर pelvic loops and jejunum are upper abdomen loops ठीक है so all of you have marked this correctly this is jejunum and again how do you identify small versus large bowel so small bowel has complete septate right because they have valvulae conniventis whereas large bowel they have incomplete septate because they have hostra they have hostra right second small bowel loops are central in location large bowel loops are peripheral in location simple all of you know this now cause of small bowel obstruction in neonates and infants, not neonates, and infants is intussusception. So quickly, we'll read about signs of intussusception. So on ultrasound, we have two important signs. Number one is donut sign, in which you get a bowel within bowel appearance. This is also known as a target sign or a donut sign. And if you just change the orientation of the probe, then you get this pseudo kidney sign. Now, both of these signs are seen in on ultrasound in intussusception. So next question comes, which is the investigation of choice. So for children, the investigation of choice is ultrasound, and if you're asked adults, investigation of choice is CCT. CCT, right? Now gold standard for intussusception is barium enema, and on barium enema you get the following signs: claw sign and coiled spring sign. Coiled spring sign. So the part where the bowel is within the bowel, when you put in a rectal contrast, it shows like a claw, right? So this is a claw sign on barium enema, and similar to it, it's a coiled spring sign. It's a coiled spring sign, right? So easy peasy. Now tell me, what is the treatment of intussusception? Now intussusception in children, since it's mostly secondary to hypertrophy of Bayer patches, and most common location is 𝐒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒𝐿𝑒 hydrocolic followed by colocolic. Right? So for both of these, the treatment of choice is pneumatic reduction. Okay, what does pneumatic reduction means? That through the rectum you push in air and try to reduce this intussusception. This is pneumatic reduction. This is done a non-surgical way. It is not done via surgery. Now, only contraindication to pneumatic reduction is perforation, right? Because of long-standing obstruction, sometimes perforation can happen. So if that happens, then you can't do pneumatic reduction because then the perf will increase. Otherwise, invest treatment of choice is pneumatic reduction. एयर एनीमा, ठीक है, एयर एनीमा एक ही बात है, न्यूमेटिक रिडक्शन उसी को बोलते हैं, एयर एनीमा को. चलो नेक्स्ट क्वेश्चन. अ चाइल्ड विद acute lymphoblastic leukemia undergoes prophylactic irradiation prior to autologous hematopoietic stem cell transplant. Which of the following will be the least affected? So we know that rapidly dividing cells are more affected. So spermatogonia will be affected. Intestinal epithelial cells, mucosa is rapidly dividing, will be affected. Bone marrow, erythroid precursor cells again will be affected. So neurons is the correct answer. Neurons are the most resistant tissue. So let's just quickly divide the radiosensitive and radioresistant things. This is one sure shot question. Has been asked multiple times, NEET PG, INI-CET FMG, very, very recently, by the way. So cell cycle, which is most sensitive, G to M, followed by M phase. So if G to M is given in the option, that is better. If that is not, the next best answer is M phase. Radioresistant phase is S phase. Most radiosensitive tissue are gonads, testis, and ovary. And resistant tissue is nervous tissue. Nervous tissue. Now, organ radiosensitive, bone marrow, and radioresistant is vagina. Blood cell sensitive, WBCs, and resistant platelets. Okay, so easy, very important table. All of you know this table. One question will definitely come from this. So keep this very handy in your revision notebook, your phone library. So what I did that for all the 19 subjects, I had a separate folder in my gallery. So which had important images of all separate subjects. So you can keep this table in that folder of radiology because this one question will definitely be asked from this table. Now let's learn a little bit about radiotherapy. So fractionated radiotherapy has been asked previously in FMG. It NEET PG में नहीं पूछा गया है, but I'm sure it is a very important topic because fractionated radiotherapy is a very important part of radiotherapy. Now we know that let's say you are treating a breast cancer and you decide that okay, total 70 gray radiation is to be given to treat this. You can't give the entire radiation at one go. So what do? You divide this into multiple doses. And each dose is known as a fraction. Right? So total dose is divided into multiple small doses. Each dose is known as a fraction. And hence the radiation therapy is known as a fractionated radiation therapy. Now, how do you give this fraction? So you give each small fraction. A normal fractionated radiotherapy is कि एक fraction में we will give 1.8 to 2.2 gray, right? Very small amount of radiation, and we'll give one fraction per day. That is, patient will come in the morning, get radiation therapy, and then go home. He'll come again tomorrow. So we give it 5 days a week: Monday, Tuesday, Wednesday, Thursday, Friday, and Saturday and Sundays are off. Right? So what is a normal fractionation? This has been asked. The dose per fraction of 1.8 to 2.2 gray given one fraction per day and 5 days a week with weekends off. This is a normal fractionation. And why is it given? Because it gives normal cells time to repair. Because during Saturday and Sunday, the normal cells which have a normal DNA repair mechanism, they repair themselves. Whereas in cancer, the DNA repair mechanism is altered. So they can't repair themselves and they die by apoptosis. So this is the mechanism of fractionated radiotherapy. Now, what is hyperfractionation? Hyperfractionation means that you are increasing the number of fractions, right? Hyperfractions. So in which case will you have to increase the number of fractions? If your per fraction dose is less, right? So if per fraction dose is less than 1.8 gray, then that type of radiotherapy is known as hyperfractionation radiotherapy, right? And so what will happen in a hyperfractionation radiotherapy? You'll give 2 doses per day, right? Morning and evening. Then next day again 2 doses. The next day again 2 doses, 2 doses, 2 doses. Then you have Saturday and Sunday off, and then Monday say again 2 doses. So this is how hyperfractionation happens. Now, similarly, there is something known as hypofractionation, and as the name suggests, hypo meaning that per fraction you are you're reducing the number of total fractions, right? Hypofractionation, आपने total number of doses कम कर दी है. So per fraction dose क्या करोगे आप, बढ़ाओगे कि कम करोगे? Per fraction dose you have to increase, right? So the per fraction dose is more than 2.2 gray, you can reduce the total number of fractions, right? So this is hypofractionation. So hypofractionation reduces the total number of radiation doses and reduces the duration of radiotherapy. It reduces the duration of radiotherapy. But does hyperfractionation increase the duration of radiotherapy? No, it does not increase the duration of RT because you are giving twice dose per day. पहले एक दे रहे थे, अब 2 दे रहे हो, कम दे रहे हो but 2 बार दे रहे हो, morning evening. So this is hyperfractionation. Okay, थोड़ा boring part होता है radiotherapy का, but we have to bear with it, right? Because one question from radiotherapy is guaranteed in NEET PG. Now let's remember important half-lives. Again, this is one table that you can take a screenshot of and keep it in your gallery radiology folder. Nothing to understand, pure learn, pure ratta. So isotope iodine 123, half-life is 13 hours. And where is it used? It is used in nuclear medicine for thyroid scans. So hot versus cold nodule, you use iodine 123. Now iodine 125 is half-life is 60 days. I remember it by 12 into 5 is equal to 60. So half-life is 60 days, and this is used in radiotherapy, right? And this is used as a brachytherapy implant. Right, permanent implant in radiotherapy, iodine 125. Right, good. Now iodine 131, I remember it कि 3 को आप 8 बना सकते हो, 3 को आप 8 बना दो, तो 8 days is the half life. And where is it used? It is again used in radiotherapy as systemic radiotherapy for metastatic papillary CA thyroid. ठीक है, radio ablation, also known as radioactive iodine ablation. Now technetium 99M, very important compound, half-life is 6 hours. This is used in gamma imaging, and it is a Source of gamma rays for all nuclear medicine scans, technetium 99M, half-life is 6 hours. 18 FDG, 18 fluorine is used in FDG PET, half-life is 110 minutes, used in FDG PET. Cobalt 60 earlier was used in teletherapy. Cobalt machines में 5.2 years is the half-life. Cesium 137 not so important, 30 years. Iridium not so important, radium not so important. Okay, now let's move on to the next question. Similar to radiotherapy, quickly tell me, 60-year-old female has to undergo radiotherapy for treatment of CS cervix stage 2B. Which of the following statements is true regarding ionizing radiation? So forget about CS cervix. The question is directly asking you about ionizing radiations. And it's asking you the true statement. So gastrointestinal mucosa is more radio resistant. Is it a true statement? No. It is radiosensitive, so it is a false statement. The radiation at a point is inversely proportional to square of the distance from the source. Yes, this is true. That radiation at a point, if this is the source of radiation, the radiation at this point is inversely proportional to distance between the source and the object. What is this? Inverse square law. This is a true statement. Now, normal cells and cancer cells will be equally radiosensitive? No. Normal cells and cancer cells are not equally sensitive. Cancer cells are more radiosensitive. Endothelial lining of blood vessels are resistant to effect of radiation? No. They are sensitive. Endothelial lining is rapidly dividing cells. Radiosensitive. Correct answer is B. And you remember this, that there is something known as hemostatic radiotherapy. And where is it given? It is given for acutely bleeding tumors. Right? What is hemostatic radiotherapy? That we know that radiation therapy is injurious to the endothelial lining of blood cells. Endothelial lining of blood cells is sensitive to radiation. So if we give a large amount of radiation to a bleeding tumor, you can stop the bleeding. So in cases where you can't resect a tumor, the tumor is bleeding actively, you can't do an embolization, all you are left with is a hemostatic radiotherapy. So remember, this is a very important point. Endothelial lining of blood vessel is sensitive to radiations. Now, quickly, easy question. Identify the imaging modality given below. What is this? Okay, so easy question है. PET ही है, PET CT. And why have you not marked full body multi-detector CT? Because you are seeing some uptake. Although you are seeing color, but you are seeing bones and uptake, right? So it's both an anatomy and a functional imaging. Very important concept. So in cerebral blood flow scan, this is only a functional image, right? So you will not see the anatomy so well. Septum EB scan, again a functional imaging, not see the anatomy well. Full body CT, it's an anatomical image, so you'll not see the function well. The only thing which combines functional and anatomy is a PET CT, right? The PET CT. Now, let's see the other important images. These have not been asked previously, but these are very important from your PG point of view, because now new questions are very commonly asked in NEET PG. Just give me a minute. Okay, right. So what is this first investigation? Tell me. Name of the investigation. Yes, Dr. Gududash, yes, you can follow this for FMG also. Tell me, what is this imaging? What is this name of the investigation? Okay, I have written here also. So पहली बात बताओ, CT स्कैन है, MRI है कि PET है? Are you seeing any colored overlap? No, you are not seeing any covered overlap. So this is an anatomical image. So it's either a CT scan or an MRI because cross section दिख रहा है हमें. Now CT है कि MRI बड़ा आसान है बताना. Bones white हैं तो CT scan है. So this is what is known as a whole body CT. Good, Gayatri, good. This is what is known as a whole body CT. And whole body CT कब करते हैं हम? When we want to see bony deformity. It is not done for soft tissue lesions, number one. It is done for bony pathology. And what's bony pathology? Multiple myeloma. Multiple myeloma. Right? So this is a whole body CT and it is done for multiple myeloma. Now, multiple myeloma के साथ problem क्या है कि now you'll say, sir, if it's a bony pathology, you're seeing lytic lesions, in multiple myeloma. Why not do a bone scan? But we know that in myeloma, bone scan is negative. Bone scan is negative. So all we are left with is an anatomical image to see lytic lesions. And why is bone scan negative? Because there is no osteoblastic activity happening in multiple myeloma. There are plasmaphytic infiltrates. Right? Plasma cells infiltrate. So you can only pick them up by an anatomical scan, like a bone scan, a whole body CT. The use of whole body CT is multiple myeloma. Now, similar to whole body CT, we have whole body MRI. Whole body MRI also is used for various bony pathologies like multiple myeloma, and it is also used for a very important pathology known as dermatomyositis. Right? It's a type of inflammatory myopathy. Remember, whole body MRI, you'll see the entire body ka MRI from the head to the to the toes. And it is used for two important pathologies, multiple myeloma and dermatomyositis. Okay, so this is a bonus information which I have given you, has not been asked previously, but it is a very potential question because multiple myeloma has been asked previously multiple times. Multiple myeloma. Now another colored investigation is perfusion imaging, right? Perfusion imaging पे भी कभी images नहीं आई हैं अभी. It will be a new question if it's asked, but this is the type of imaging which you see. Now, where do we see perfusion imaging in the brain? It is used in stroke imaging. It is used in stroke imaging. Now, stroke imaging, why do we use it? To see what? Penumbra. To see penumbra. So number one, penumbra is not identified on plain CT scan or a plain MR. You have to do a perfusion imaging to see penumbra. And what is a penumbra? It is a viable tissue, meaning that there is oligemia. Oligemia matlab reduced blood flow, but no infarction. वेरी इंपॉर्टेंट कंसेप्ट. ऑलिगीमिया का मतलब है कि ब्लड फ्लो कम है बट इंफाक्शन नहीं है, टिश्यूज डेड नहीं है, सेल्स डेड नहीं है. सो यू कैन सेव देम. एंड हाउ डू यू सेव देम? बाय नोइंग विच एरिया इज पेनम्ब्रा. एंड हाउ डू यू नो इट? बाय द हेल्प ऑफ सीटी परफ्यूजन. सो इन सीटी परफ्यूजन we talk about two important parameters, that is cerebral blood flow and cerebral blood volume. Now remember, in an infarct, that is a dead tissue, both cerebral blood flow and cerebral blood volume will be low. So cerebral blood flow कम है and cerebral blood volume भी कम है. So जो एरिया यहाँ पे ब्लू दिख रहा है वही एरिया यहाँ पर भी ब्लू दिख रहा है. मतलब cerebral blood flow and cerebral blood volume are matching. But in an penumbra, in an ischemic penumbra, in which the blood flow is less, but CBV is normal, you will see that there is a mismatch. There is a mismatch between the two maps. In an ischemic penumbra, how do you identify penumbra? The cerebral blood flow will be less, but the volume will be normal. And why is blood volume normal in penumbra? Because of collaterals. Because of collaterals. Very important concept. So imagine if this is the brain and this is the blood supply to it. In stroke, what happens? That there is a clot which has logged into the main artery. So what happens due to this clog? The blood flowing into the vessel will reduce, कम हो जाएगा. But what happens in the brain, because of there is anastomosis between the anterior communicating artery and posterior communicating artery, this area gets collateral blood supply. And collaterals में blood flow कैसे करता है? धीरे धीरे flow करता है collaterals में flow. So you will have that the cerebral blood volume is normal, but blood flow to that area is reduced. Right? And because cerebral blood volume is normal, the cells are still functioning, but at a reduced capacity. So if you are able to remove this clot, then this tissue is salvageable. This tissue is salvageable tissue. So what is this process known as? This is known as mechanical thrombectomy. Right? Mechanical thrombectomy का नाम है. So next question comes, what is the window period? कब तक कर सकते? Tell me this. अभी तक you have been patiently listening to what I've been saying. Now this is a medicine topic, medicine things I'm asking you. What is the window period for IV thrombolysis? What is the window period for mechanical thrombectomy? Yes, so for IV thrombolysis, the window period is 4.5 hours. And for mechanical thrombectomy, what is, yes, the mechanical thrombectomy, the window period is up to 24 hours. Up to 24 hours with CT perfusion. With CT perfusion, right? And without CT perfusion, if the place does not have CT perfusion, it is 6 hours. So अगर आपको एक कोई ऑप्शन मार्क करना है, you have to mark 24 hours. 24 hours is the answer. CT perfusion पर अगर आपको penumbra दिख रहा है, you can save that area up to 24 hours. 24 hours बाद everything gets infarcted. So very important concept. Very, very important concept. Now tell me two important severity scores for stroke. One is a clinical score and another is a CT score. So clinical score का नाम मैं बताऊंगा, CT score का नाम आप बताओ. So what is the clinical score? NIHSS score. NIHSS की full form है National Institutes of Health Stroke Severity Score. And what is the CT score? Aspects. Aspects की full form है Alberta Stroke Program Early CT Severity Score. Okay, two important severity scores of stroke. थोड़ा tongue twister भी है ना, severity scores in stroke. चलो. Now tell me this investigation. What is this investigation? ठीक है, MR दिख रहा है क्योंकि बोन्स हमारी हैं, ये बोन है एक ह्यूमरस, ये ब्लैक है, so this is an MR. But what interesting is happening here? You are seeing that the joint space, joint fluid is appearing very bright. Okay, now this is what is known as an MR arthrogram. ठीक है, दिस इज एन MR arthrogram. MR arthrogram में क्या करते हैं हम? We inject gadolinium into joint. ठीक है, so for example shoulder joint है, you inject gadolinium into the shoulder joint, so the shoulder joint distends. And where is it used? It is used to see the labral pathologies and ligament tears. ठीक है, good Gayatri, this is an MR arthrogram. Now tell me, what is this investigation? All of you know this. This is DECT, or dual energy CT. What is meaning by dual energy? कौन सी दो एनर्जी पर हम करते हैं CT scan? Which are the two kVps that we use in this dual energy CT? 80 and 140. 80 and 140 kVp पर हम यूज करते हैं इसको. ठीक है, लिखा हुआ भी है यहाँ पर 80 and 140 kVp. And what are the uses? दो यूज आप याद रखिए. One is in gout and second renal stone characterization. Now gout में we don't see uric acid, we see crystal. Uric acid does not deposit. Monosodium urate crystal deposits. Chalo. Now what is this investigation? So what are we identifying here? We are identifying parathyroid adenoma. So this is a 2D scan and this is a 3D scan for parathyroid adenoma. So this is a SPECT and this is a gamma imaging. Now for parathyroid adenoma, what is the investigation of choice? It is sestamebe SPECT. So sestamebe SPECT is a 3D image and this is the investigation of choice. Okay. Now what is happening here? So sequential scans have been provided to you and this looks like a urinary system. Kidneys दिख रही है and bladder दिख रहा है. So something related to renal scan. What type of a scan is this? Tell me, what type of a scan is this? Now, this is what is known as a renal dynamic scan. This is a renal dynamic scan. ठीक है, आपकी पूरी न्यूक्लियर मेडिसिन रिवाइज करा रहा हूँ बेसिकली मैं, right? So renal dynamic scan is used to see kidney function. Right? And if you're asked about one compound which is given in renal dynamic scan, it is MAG3, because MAG3 is excreted both by GFR, glomerular filtration, and tubular secretion. So it tells you about the overall renal function. And दूसरा कौन सा होता है? दूसरा हम यूज करते हैं DTPA कंपाउंड. DTPA has only glomerular excretion. So it is not used to see kidney functions. It is only used to assess GFR. ठीक है, बट अगर आपको ओवरऑल किडनी फंक्शन देखना है तो यू यूज अ MAG3. Now what is happening here? You see that on the, this is the दिस इज लेफ्ट, दिस इज राइट. सो न्यूक्लियर मेडिसिन में उल्टा होता है राइट लेफ्ट. व्हाई? बिकॉज हम पीछे से स्कैन करते हैं, पीछे फिल्म होती है हमारी, राइट. सो इसमें राइट लेफ्ट उल्टा होता है, रिमेंबर, एज कंपेयर टू सीटी. याद रखना ये बात हमेशा. सो what is happening here, that there is contrast accumulation on the left hand side. There is contrast accumulation on the left kidney persistently. The right kidney पहले तो contrast ले रही थी, it was showing early contrast enhancement, but then gradually over 20 minutes the contrast has excreted out of it. So there is contrast pooling in the left kidney, and this is how your PUJ obstruction look like. This is a case of left PUJ obstruction. Right, so renal dynamic scan, this is a case of left PUJ obstruction. Okay, now this is how a DMSA scan looks like. DMSA is a S for static scan and S for scarring. So it is used to see renal scars. And in which condition do you see renal scars? Vesico-ureteric reflux, or VUR, vesico-ureteric reflux. So this is how your VUR looks like. This is an MCU or a micturating cystourethrogram. The patient is voiding here. ठीक है, urethra दिख रही है हमें, right? And while voiding, you see that there is reflux of contrast into the ureters and the renal pelvis. This is vesico-ureteric reflux. And what is the name of this investigation? This is MCU or micturating cystourethrogram. दूसरा क्या नाम है इसका? VCUG, voiding cystourethrogram. And diagnosis is vesico-ureteric reflux. Great, right. So you're right, Dr. Marrow. For renal scarring, it's DMSA. For function, it's DTP and MAG3. ठीक है, चलो, good. Let's move on to the next question. Finally, we are done with nuclear medicine scans. Now, easy peasy. Quickly, you will tell me what is this. Patient brought to the casualty following road traffic accident. On examination, the patient is conscious. His BP is 90/60. So hypotensive patient है. Respiratory rate is 40. And pulse rate is 120. So it is a tachypneic patient, tachycardia and hypotension. What is the next best step in management? So what are you seeing here? You are seeing that there is a left pneumothorax. So this is a left pneumothorax, and not just a simple pneumothorax. There is tension because there is hypotension. So this is a left tension pneumothorax. And what is the next best step? You will do a needle thoracotomy. And where do you do a needle thoracotomy? In adults, you do it in the 5th intercostal space, mid-axillary line. And in children, you do it in the 2nd intercostal space, mid-clavicular line. Okay, so needle thoracotomy is the answer. Now quickly tell me, best X-ray view for pneumothorax is PA expiratory view. If you're asked best X-ray view, but if you're asked best investigation is NCCT. Now what signs do you see on EFAST? On EFAST, you see barcode sign or stratosphere sign. And management, we've already covered. In an unstable patient, you'll do a needle thoracostomy followed by ICD. And in a stable patient, you'll put in an ICD. So this is how a pneumothorax looks like. You see air with no vessels. This suggests a free air in the pleural cavity. Again, a free air in the pleural cavity. You don't see any vessels, and there is a visceral pleural line. All of you know how to identify a pneumothorax. Now, sometimes this pneumothorax can be very subtle. So in your NEET PG exam, in both INI-CET, you're given an option to zoom the image. So please zoom the image, right? तभी आपको दिखेंगी चीजें. So here you see this beautiful visceral pleural line. And उसके बाहर You don't see any vessels here, right? Don't see any vessels here. So this is a pneumothorax. Very subtle finding. You have to zoom the image to know it. Now tell me, supine X-ray, supine chest X-ray, what is the sign of pneumothorax? Because most of the time pneumothorax patients are lying on bed. You can't ask them to stand up and do an expiratory PAView. So most of the times the X-ray done are supine chest X-rays. On supine chest X-ray, what is the sign of pneumothorax? Good, great. So good, Arpit. The sign is deep sulcus sign. Name of the sign is deep sulcus sign. Now all of us know ultrasound findings of pneumothorax. M mode पे it is barcode sign or seashore or stratosphere sign, and normal lung shows seashore. So normally हम C पर जाते हैं. We normally go to the seashore. So seashore sign is seen in normal lung. This is on M mode. But B mode पे normal B mode ultrasound, what are the signs? So you see absence of lung sliding sign, and if you're asked about the most specific sign of pneumothorax, it is lung point. So remember, this is a very important point. Most specific sign of pneumothorax is lung point. Right, Arpit? Most specific is lung point. Of air fluid level, all of us notice hydropneumothorax. Next question, again a previous year topic. 25-year-old male came to the OPD with chronic knee pain for the past 4 months. So there is no acute history. 4 months से pain हो रहा है. Chronic knee pain. No history of trauma. X-ray of the knee has been depicted. Most probable diagnosis and management. So what do you see? You see that there is apparent breakage in the patella, right? And if you look carefully, the cortex is continuing at the fracture site. Now, if there is cortical continuity, that means that these two are separate bones. The hallmark of a fracture is cortical disruption. See, again here, you see that this is the normal cortex and this is a separate bone like it. This type of patellar appearance is known as a bipartite patella, right? There is something known as a tripartite patella also. Tripartite patella भी होता है. ठीक है, so bipartite पूछा है तो tripartite भी पूछ सकते हैं. But what you have to see is the cortical continuation. Just give me a minute. Hi guys, sorry for that. There was some burning smell that I could smell, so I had to go and check. Sorry for that. Everything is fine. Yeah. So I was at bipartite patella. That normally, when you look at fracture, you have to see the cortical discontinuity. If you are seeing cortical continuity along the fracture line, that means that they are two separate bones and not a fracture. So this type of patella is known as a bipartite patella. Uh, the pointers toward it is a no history of trauma, long standing history of a knee pain, and this is a developmental abnormality. So what you have to do is do an opposite limb x-ray, give patient some painkillers, ask him to do some physiotherapy, and this will resolve on its own. So conservative management is a treatment for a bipartite patella. If it was a fracture, so this is how opposite limb X-ray looks like. It is seen on both sides. So here is also a separate bone. Here is also a separate bone, and this is most commonly located in the superolateral aspect of patella. Right, superolateral aspect पे होती है ये bipartite patella. Now, in comparison, in a fracture, you will see that the cortex is discontinued here. Yeah, bipartite is always bilateral. That is how you differentiate it from a fracture. Okay, so this is a fracture. This is a patellar fracture. And here you do K wires or tension band wiring. Right? So Juno, why does it occur? It is a developmental abnormality. It happens from birth. And why does it happen from birth? Because patella ossifies from multiple ossification centers. So sometimes these two ossification centers don't fuse and they develop into separate bones, which are linked together by cartilages. Right? So bony fusion nahi hota hai unka. That's why you see two separate bones. That's the developmental origin of bipartite patella. Now, next question. 50-year-old chronic alcoholic male with history of trivial trauma 3 weeks back. So elderly, trivial trauma, OPD with complaints of headache. NCCT is advised. What is the diagnosis? So very easy. All of you will guess what the answer is. You see that there is bleed on the left hand side. It is crossing the sutures and it is a banana shape or a concavo-convex bleed. What is this? This is an FDH. All of us know what is the difference between FDH and EDH. So EDH is a high velocity severe bleed. So high velocity impact arterial bleed, whereas FDH is a trivial trauma elderly patient having a venous bleed. The most common artery in EDH is a middle meningeal artery, and most common artery here is an emissary vein. Now, EDH usually has a biconvex appearance, but it is not a rule. What you have to see is sutures. So, if your frontoparietal and fronto-occipital sutures are not crossed, this is likely an EDH. So, bleed does not cross the sutures, but it can cross the midline, right? Because midline में frontal bone में कोई suture नहीं होता है, occipital bone में कोई suture नहीं होता है. So यहाँ पर अगर कोई bleed होती है frontal और occipital में, it can cross the midline. But अगर कोई यहाँ पर bleed होगी, यहाँ पे there is suture, sagittal suture. So here it cannot cross, right? So crossing the midline meaning in the frontal and the occipital part. It is usually associated with skull fractures because of the high velocity impact. FDH can cross the suture, so you see that the bleed is crossing the suture, but it cannot cross the midline. So it can't go like this. It can't go like this. It has to go like this. This is what is meant by it cannot cross the midline. Okay. So look at this image. The FDH at the level of Fox has to dip along with the Fox cerebri. This is FDH, whereas EDH can go beyond the Fox. This is EDH. Now, SH, how does SH appear? It appears like a star-shaped bleed in the cisterns. But apart from cisterns, remember SH can happen in the sulci also. So in the cerebral sulci, if the bleed happens, this is sulcal SH. And if it happens in the basal cistern, this is known as cisternal SH. Cisternal SH. This is what is known as a star-shaped bleed. And for cisternal SH, most common cause is berry aneurysm. And for sulcal SH, most common cause is trauma. Correct? Now, SH typically presents with thunderclap headache or the worst headache of one's life, and there can be associated neck rigidity. So only type of bleed which happens with neck rigidity is SCH. It mimics meningitis. Why? Because it happens in the subarachnoid space, which irritates the meninges. So it can cause neck rigidity. The most common cause, if you're asked overall, it is trauma. Investigation of choice is NCCT. The most common cause of non-traumatic SCH is berry aneurysm. What is the most common location? Tell me in the chat box, what is the most common location? A non-traumatic SCH, let's say patient has SCH on NCCT, there is no history of trauma. So it's a non-traumatic SCH. Now, what is the most common cause of non-traumatic SCH? We have read berry aneurysm. Now, how do you identify berry aneurysm? Do a CT angiography. Now, gold standard for SCH is DSA. Okay. Now, what do I mean by gold standard of SCH? Sometimes in the question you can be asked CT angio negative SAH. What does CT angio negative SAH means? That there is subarachnoid hemorrhage on non-contrast CT. There is subarachnoid hemorrhage on non-contrast CT, but when you do a CT angio, there is no aneurysm which you can find. This is what is known as a CT angio-negative SCH. And for this, the investigation of choice is again a DSA. Investigation of choice is DSA. Okay, good. Most common location of berry aneurysm is ACOM, anterior communicating artery. Okay, good, Tanya. Circle of Willis is a very broad term. Circle of Willis में artery localize करनी पड़ेगी भाई. It is anterior communicating artery, ACOM artery. Now next, a young male presented with. So let me ask you two more important questions. Severity scales of SH. You tell me one clinical and one CT. So what is the clinical severity scale of SH? Hunt and Hess scale. And what is the CT scale? Yes, one is WFNS also. WFNS भी है. Good. WFNS and Hunt and Hess. Good, Arpit. CT scale बताओ क्या है? CT का नाम है Modified Fisher Scale. Modified Fisher Scale. Chalo. Next question. A young male presented with proptosis of the right eye and there was a history of road traffic accident 2 years back. The imaging revealed a homogeneous lesion in the frontal sinus. Most probable diagnosis is. Okay, so this was a previous question asked and there was a new question then. But now it has become a PYQ. So आपको क्या दिख रहा है कि जो frontal sinus है उसकी bone intact है यहाँ पे. एंड यहाँ पर एक बड़ा सा ऐसे लीजन दिख रहा है जो कि नोज तक जा रहा है. दिस इज हाउ टिपिकल फ्रंटल म्यूकोसील अपीयर्स, राइट. एंड आई विल शो यू मोर इंपॉर्टेंट, दिस इज नॉट अ जेएनए. जेएनए का कॉज जब भी आपको हिस्ट्री में दे रखा होगा, जेएनए विल हैव epistaxis as the complaint, it will not have proptosis as a complaint. So this answer here is a frontal mucocele, and I'll give you more important images which are more representative. So this is how typical frontal mucocele appears. The frontal sinus has this T1 hyperintense and T2 hyperintense contents within the frontal sinus, and on giving contrast, this is T1 plus contrast, you're giving contrast, there is no enhancement, right? This means that it is not a solid component, it is a mucocele, mucin rich content. Why? T1 hyperintensity tells us it is mucus rich. And this is how a typical frontal mucocele appears. ठीक है, so remember this image. MRI has not been asked, CT was asked previously, but MRI can be asked. It's a very important question. ठीक है, so this is frontal mucosae. Now how does optic nerve meningioma looks like? So this is a case of optic nerve meningioma, right? You see that the optic nerve has this homogeneously enhancing thickening along it. So this is an optic nerve meningioma, and this is an example of your juvenile nasopharyngeal angiofibroma. So typical location of a JNA is in the nasal cavity and in the pterygomaxillary fissure. Nasal cavity plus infratemporal fossa mass. And this typically has epistaxis as a complaint, and it happens in children. Children का tumor है, right? Now let's come to the next question. Easy. Tell me what is the diagnosis? Very, very easy. Following appearance of IVP is caused by. So you see that there is both cystic dilatation in the distal end of ureters. And what is this appearance known as? Cobra head or adder head appearance. Right? So this is a uretrocele. These are bilateral uretroceles. And this is ultrasound appearance of uretroceles. You know, ultrasound नहीं दिया गया अभी तक. Ultrasound has not been given for uretrocele, but it's a potential question because IVP has been given. Now, if they have to repeat the PYT, they have to change the image. How will they change the image? They will give an ultrasound, and what you will see on ultrasound, you will see the bladder, and you will see the region of vesico-ureteric junction, VUJ, vesico-ureteric junction, and at the VUJ, you will see that the ureters are dilated terminally. Cystic dilatation of the terminal part of ureter is uretrocele. This is how uretrocele appears on ultrasound. Okay, ultrasound image is very important. Has not been asked previously, but will be asked now. This is not an MCU. This is an ultrasound. Now this is an IVP. And what is this sign known as? Tell me the sign and the diagnosis. So name of the sign is flower vase appearance, also known as shaking hand appearance. And the diagnosis is horseshoe kidney. Okay. Now tell me what is this image. First tell me what is the investigation and what is the diagnosis. No, this is not RG. You know, every time I ask a question for MCU, every time the answer is RG. I don't know why. Why is it RG? Why are you saying Tanya it's RG? Bladder injury. No, it's not bladder injury. What is this modality? What is happening here? This is the urinary bladder. This is the urinary bladder. This is the urethra. So patient is micturating, right? That's why you're seeing both the bladder and the urethra. If it is an RGU कैसे करते हैं हम? Urethra को cannulate करते हैं and then we put in a dye. So in an RGU, retrograde urethrogram, we only see the urethra. We don't see the bladder. If you're seeing the bladder and the urethra, that means that the patient is micturating on the table, right? The patient is micturating on the table and you are taking an X-ray. That is how an MCU is taken. So this is an MCU or a micturating cystourethrogram. And what you are seeing here, that while doing an MCU, there is filling in of the ureter also, and the kidney pelvic little system is also getting opacified. So this is BUR, the psychoureteric reflux happening. Now, what else is happening here? You see that in the urethra, there is a constriction. There is a constriction at the posterior urethra, right? The posterior urethra is dilated. This is the posterior urethra, which is dilated. And below the posterior urethra, there is this narrowing, right? So this is whatever typical of posterior urethral valve. And this appearance is known as keyhole appearance. Okay, this is a keyhole appearance. Now tell me, what is this? Let's see some other important spotters of IV of kidney. So paintbrush appearance of kidney is seen in diagnosis, medullary sponge kidney, medullary sponge kidney. Now putty kidney has been asked previously. How do you identify putty kidney? In putty kidney, you will see cortical calcifications. You will see cortical calcifications. And this is a previous question. What else do you get here? You get sterile pyuria. Now, medullary nephrocalcinosis, you see calcifications in the region of medulla. So this is the typical X-ray that you get. Multiple dotted calcifications in the region of the kidney. This is medullary nephrocalcinosis, and the most important cause that you have to remember is hyperparathyroidism. Hyperparathyroidism. Okay, next, let's move on to the next. Identify the structure marked in the following MRI scan. So it's a very easy question. So this is a cerebellum that we are talking about, posterior part, and let's just enumerate, let's just label the rest of the structures also. So this is the corpus callosum, this is the genu, the splenium of corpus callosum. What are the other structures? So this part here, this is the optic chiasma, this is the infundibulum of the pituitary stalk, and this is the pituitary gland. This is the stalk of pituitary. Can someone tell me what this structure is? This is midbrain, this is pons, this is medulla oblongata, and this is vermis. This is fourth ventricle. What is the orange structure? Good. So orange structure is fornix. And between the fornix and the corpus callosum midline, what do we have? We have septum pellucidum. So these are all the important structures in the mid-sagittal plane. Now in the axial plane at the level of basal ganglia, we have the caudate nucleus. This is the putamen, globus pallidus, thalamus. Now this is the pons, middle cerebellar peduncle, fourth ventricle. This is the fourth ventricle. Now let's label the important ligaments of the knee. So attaching on the posterior aspect, right? This ligament here is the PCL. This has been asked previously. What is this attaching on the anterior aspect? This is the ACL. Now these two bow-type shaped structures, if you're seeing the if you're seeing the fibula, not patella, sorry, if you're seeing the fibula, this means that this is the lateral meniscus. And if you're not seeing the fibula, that means these two structures here are medial meniscus. Now, there is something known as a double PCL sign that is in the mid-sagittal section of the knee. You're seeing the patella, you're seeing the femur, this is the patella, this is the femur, this is the tibia. This is the mid-sagittal section. In the mid-sagittal section of the knee, you are seeing one structure here and another structure here. Looks like a double PCL sign. Where is it seen? Where do you see double PCL sign? This is seen in bucket-handled tears of medial meniscus. Medial meniscus. Now, what is this showing here? This is the ACL, which is crumpled like this. And in the region of ACL, you have this fluid signal. Now, this is how a typical ACL tear looks like. And what are the signs of ACL tear? ACL draught, anterior draught test, Latchman test, right? All these signs you know for ACL tear. Now, on the coronal plane, this is the coronal image. You see lateral and medial. This is the medial collateral ligament and the lateral collateral ligament. This here is the medial collateral and this one here is the lateral collateral ligament. Okay, now let's move on to the foot. So important tendon here is the Achilles tendon here. And this important fascia is the plantar fascia. Right. So what is this image showing you? In the region of the Achilles tendon, you see there is discontinuity and there is fluid signal in the region of discontinuity. So this is how a typical Achilles tendon tear looks like. Okay, now let's move on to the next question. All the following could be the cause of the given X-ray finding except. So what are you seeing? You are seeing air under diaphragm. And we know that air under diaphragm happens in pneumoperitoneum. So dural ulcer perforation, can it cause pneumoperitoneum air under diaphragm? Yes. Post laparoscopy, very important. Can you see post laparoscopy air under diaphragm? So up to 72 hours. Yes, you can see pneumoperitoneum. So again, this is correct. You can see air under diaphragm under post laparoscopy condition. Chilaiditi syndrome. Chilaiditi syndrome is pseudo pneumoperitoneum. Pseudo-pneumoperitoneum, that is, colon gets interposed between the diaphragm and the liver. So in that case also you sometimes see air in the diaphragm. Now, acute interstitial obstruction on X-ray, you see air, fluid, levels. Right? So the correct answer here is acute intestinal obstruction. You don't see air in the diaphragm normally in acute intestinal obstruction. Now, if it's perforated, then only you will see air in the diaphragm. So, investigation of choice for intestinal obstruction is CECT. Now, what is the rule of 3, 6, and 9? So, this is the maximum diameter of bowel which we take as normal. So, after what diameter do we call a bowel dilated? So if it's a small bowel is labeled dilated after 3 centimeter. Large bowel is labeled dilated after 6 centimeter, and cecum is labeled dilated after 9 centimeters. Right? Now tell me an important sign which is shown here. This is a sign of intestinal obstruction. So you see that the small bowel loops are dilated, and these small bowel loops have some air within it. This is known as small bowel feces sign. And this tells you that the obstruction has been there for quite some time. 2 to 3 days of obstruction hai, so that the contents in the intestine have now fermented. They are producing air. So this is a sign of subacute intestinal obstruction. Okay, so this is small bowel feces sign, subacute intestinal obstruction. Now identify the sign shown in the image. So what is this sign? Sawtooth sign, apple core sign, corkscrew appearance, या string sign. So string sign में तो string होगा, वैसे तो दिख नहीं रहा तो ये नहीं है. Apple core sign में क्या होता है? एक जगह डायलेटेड होता है, फिर नैरोइंग होती है, फिर डायलेटेड होता है, तो वो भी नहीं है. तो corkscrew भी ऐसा दिख रहा होता है और sawtooth भी ऐसा दिख रहा होता है. Now ये क्या है? So you see some diverticulae coming out. So this is diverticulosis. And what is this imaging? Barium enema. So barium enema, diverticulosis, you see sawtooth appearance, sawtooth sign. Answer is sawtooth sign. Now, how does apple core sign look like? This is apple core sign, you see it in CA colon. This is corkscrew appearance of esophagus, seen diffuse esophageal spasm. And this is the string sign of contour. Where do you see? In ileocecal TB. Ileocecal TB. Now, string sign in stomach. Can someone tell me where do you see string sign in stomach? Yes, so this is seen in infantile hypertrophic pyloric stenosis, IHPS. Okay, ortho question, I'll not do it in detail. History of trauma, limb shortening was noted, nerve commonly injured in this injury. So what do you see here? You see that the right hip is dislocated. ये acetabulum है and femoral head is outside the acetabulum. So this is a hip dislocation. Now most common hip dislocation is posterior. ठीक है, so posterior कौन सी nerve होती है? Posterior हमारी sciatic nerve होती है. So sciatic nerve is the most commonly injured nerve in this case. Next, postmenopausal female with intermittent pelvic pain presents to the OPD. X-ray is shown below. What is the diagnosis? Now this is a very very important X-ray and पहले पूछा गया है ये. Postmenopausal female है and female में whenever you are seeing any calcifications in the pelvis, don't dump into a bladder calculus, क्योंकि bladder calculus ही most commonly देखते हैं हम pelvis में. But in a female, always and always see what is the type of calcification. So in this you see that there is stippled calcification. ठीक है, this type is seen in a fibroid. This is seen in a fibroid. ठीक है, so all of you have got this correct. This is a fibroid. And this is how bladder calculi look like. Bladder calculi These are usually multilamellated. Multilamellated. So you see multiple layers. This is bladder calculi. Again, even if they're small, they'll show multiple layers. This is bladder calculi. Now, a type of bladder calculi has pointy edges. Okay. So, bladder calculi with pointy edges. This type is known as Jackstone calculus. And can someone tell me what is this? What is the third image showing you? Multiple cylindrical shape radiopacities in the abdomen. What is this? Right. So these are nothing but pellets of cocaine, which the this mule has, not mule, which this person has swallowed. So these are known as cocaine mules, these people, and this syndrome is known as body packer syndrome. Body packer syndrome. Okay? You will see these pellets. Inside the intestines. Okay, next question. A person presents 10 weeks after pancreatitis. What is the diagnosis? So pancreatitis की history है. You are given a large fluid collection. After a pancreatitis, there is nothing but a pseudocyst, right? Pancreatitis के बाद कुछ भी cystic collection abdomen में इकट्ठा होता है. You have to mark pseudocyst as an answer. Next question. 35-year-old female presents with dysphagia, regurgitation, and weight loss. What is the diagnosis? What is the diagnosis? Okay, so regurgitation, dysphagia, and weight loss. What are you seeing? You are seeing a bird beak appearance on barium swallow. The diagnosis is achalasia. Now, regurgitation can happen in achalasia. The regurgitation happens only in Zenkers. It can happen because there is a stasis of food in the esophagus, right? It is dilated. So regurgitation can happen in achalasia cardia. Another important thing, in achalasia cardia, we know that there is dysphagia to liquids more than solids. What is the investigation of choice? It is esophageal manometry. Esophageal manometry. Now, what is the classification system that is there on esophageal manometry? It is Chicago classification. Now, what is the treatment? So the surgical treatment is Heller's myotomy, but the endoscopic treatment is POEMS. Right? Now, post POEMS, after POEMS, to see success of surgery, what type of investigation do you do? Post POEMS, what type of investigation do you do? Now you do something known as timed barium swallow. Timed barium swallow. So what happens that you ask the patient to drink barium, right? Now what will happen? Initially the barium will get stagnated, but if it's a successful surgery at 1 minute, 5 minutes and 7 minutes, you will see that the column of barium पहले यहाँ पर था, अब इतना आ गया, अब इतना आ गया, अब इतना आ गया. You will see that the column of barium with successive passages of minutes reduces. This means that the surgery is successful, and the success of surgery caused by this timed barium swallow. Right? So this is a new investigation which can be asked, timed barium swallow. A newborn baby presented with respiratory distress. What is the diagnosis? ठीक है, newborn respiratory distress, you see there are no bowel loops in the abdomen, there is no stomach here, all the bowel loops have now herniated in the left side. This is a congenital diaphragmatic hernia. Most common is the posterolateral type on the left side, also known as Bogdelic hernia, causes pulmonary hypoplasia, respiratory distress है, so bag and mask ventilation is contraindicated. You have to do invasive positive pressure ventilation. चलो, now again if this is an X-ray which is given, you see that retrocardiac there is an air bubble. This is how a hiatal hernia looks like. And again a case of neonate with respiratory distress. But if this X-ray is given to you and you see this fluid in the between the fissures of the lung, this is known as interfissural fluid. Interfissural fluid in the interlobar fissures. This is diagnostic of TTN, known as transient tachypnea of newborn. There is an important sign which is there in TTN. You just remember the name of the sign, that is sufficient, known as a double lung point. And this is a transient tachypnea, so the treatment is conservative when a follow-up chest X-rays are needed. Now again a previous question asked in INI-CET, a 19-year-old male with high-grade fever and productive cough. What is the diagnosis? Right, so right heart border is silhouetted, so where will you localize this? You localize this to the right middle lobe, and a simple answer is the right middle lobe consolidation. The next question, again a very easy question, so I'm not spending a lot of time because this is something you already know and you read it in orthopedics also. 35-year-old male presents with pain and swelling in the wrist joint. There is no history of injury. X-ray is shown below. What is the most likely diagnosis? So painless swelling, no history of trauma, so we are dealing with a tumor. Now it is a 35-year-old, so an adult, skeletally mature. This is a tumor in the epiphysis reaching till the joint. So what is this? This is a giant cell tumor. So this is a giant cell tumor. What is the second name of giant cell tumor? Osteoclastoma. Again, let's see all the important bone tumors now one by one. Young child, 15-year-old. Location of the tumor is metaphysis. What is the diagnosis? Aneurysmal bone cyst. Now again, metaphysis location, right? Unilocular lesion, and you see a fragment of bone. What is the name of the sign? Fallen fragment sign. Diagnosis is simple or a unicameral bone cyst. Now again, tumor of small bones and hand. Tumor of bones of small, tumor of bones of hands, right? So you see a lytic lesion in the central part of the bone. No cortical destruction. So if there is no cortical break, we know it's a benign tumor. What is the diagnosis here? The diagnosis is enchondroma. What is Olier's disease? Multiple enchondromas. And what is Maffucci syndrome? Enchondroma plus soft tissue hemangiomas. Chalo. Young adolescent with night pains, and you see this lesion with surrounding sclerosis. Okay, easy question. Diagnosis is osteoid osteoma. And what is the treatment? Treatment is radiofrequency ablation. Next question. The following appearance is shown as shown is seen in, ठीक है, previous question है, cannonball lesions होते हैं, cannonball lesions are seen in metastasis. Now remember, these are cannonball lesions are big lesions and they are random and they are bilateral. They are bilateral, big and random lesions. Now in comparison, TB में भी मिल सकते हैं, but in TB what you see typically are miliary TB. Miliary TB you get multiple small millet sized, again bilateral and again random distribution. ठीक है, miliary TB में random distribution मिलता है. Now you will see, you will ask me, sir, but you said tree in bud distribution या centrilobular distribution मिलता था TB में तो. Now this is seen in endobronchial TB. Right? Endobronchial TB मतलब वो TB जो hematogenously has not yet spread. It is localized into the bronchi and spreading by bronchi. That spread shows tree in bud appearance or centrilobular distribution. But if it's a hematogenous spread of TB, like it happens in HIV or it happens in immunosuppressed patients, then you get this type of picture. This is known as a miliary TB. And this is a normal phenotypic appearance. What is the pathological name for this? This is progressive TB. Right? Now this can either be primary progressive or secondary progressive TB, and it tells you that there is hematogenous spread of TB which has happened, and this happens in immunocompromised patients. So you'll see multiple small nodules spread bilaterally, randomly, and very tiny. Now what is this? This is a single nodule. This is a single nodule. So this is known as a solitary pulmonary nodule. Solitary pulmonary nodule. And what is this type of calcification that you see? Good. Okay, good nephrotoxic. The type of calcification that you see here are known as popcorn calcification, and the diagnosis is pulmonary hamartoma. Pulmonary hamartoma. Okay, so popcorn calcification in lungs is pulmonary hamartoma. Tell me popcorn calcification in breast किस में मिलता है? Popcorn calcification in breast. Yes, this is involuting fibroadenoma. Involuting fibroadenoma. Good. ठीक है. Involuting मतलब जो कि dying, मरने वाला fibroadenoma. The fibroadenoma which is regressing in size, which is now dystrophic calcification. It is like dying in size. This is fibroadenoma, involuting fibroadenoma. Now this is how a CA lung appears. So CA lung most commonly occurs in the upper lobes. Upper lobes more common होता है. It has a spiculated margins. So you see these spiculated margins, these are suggestive of this is not a TB, this is not a hamartoma, this is not a benign pathology, this is a malignant pathology, likely a CA. Chalo, 30-year-old patient has a history of car accident 2 years ago and now experiencing pain and swelling in the same area. His X-ray is shown below. What is the diagnosis? So on the X-ray, what do you see? You see a separate bone lying within the bone. Whenever a bone is lying within the bone, this is a sequestrum. And sequestrum is hallmark of chronic osteomyelitis. Again, this is a CT image. This was asked previously. This is a PYQ. This CT image was asked for chronic osteomyelitis. Earlier, X-rays were asked. Again, this is a sequestrum. And this is involucrum. Again, diagnosis is chronic osteomyelitis. Now, what is this? Again, a single answer hai. Swelling hair with sunburst, periosteal reaction. What is the diagnosis? Osteosarcoma. Okay, all of you know this. No need to comment. Now, this is an interesting X-ray. A 25-year-old male injured his left shoulder. This is the right shoulder, by the way. Sorry. When he was playing rugby, currently he feels pain in his right shoulder and is unable to move his arm. X-ray was shown. Which lesion does it depict? So, what does the arrow show? Is it a Bankart, bony Bankart, reverse hill sac, or a hill sac? Some are saying A, some are saying D. Arpit, is it a Bankart or a hill sac? So remember, hill, H is for hill sac, H is for humerus. तो हिल सैक रीजन ह्यूमरस पे होता है, ठीक है. बैंकार्ट लीजन कहां पर होता है? वेयर डज बैंकार्ट अकर्स? इट अकर्स इन द ग्लेनॉइड. ग्लेनॉइड इज पार्ट ऑफ स्कैपुला. तो यहां पर अगर आपका होगा दिस इज बैंकार्ट एंड दिस इज हिल सैक. Right? So this is happening on the humerus. Humerus पे दो जगह हो सकता है. So if it happens on the posterior superior aspect, it is known as a hill sac lesion. If it happens in the anterior inferior aspect, this is known as a reverse hill sac. And I'll show you why these two lesions occur in these two places. Right? So hill sac टॉप ऑफ ह्यूमरस पे होता है, हिल पे जाके टॉप ऑफ ह्यूमरस पे होता है, एंड दिस हैपेंस इन एन एंटीरियर शोल्डर डिसलोकेशन. Right? So look at this image. So when the shoulder undergoes an anterior dislocation, the posterior superior part of the humerus touches or hits the anterior part of glenoid. Right? So the lesion on the humerus will be on the posterior aspect, and this defect on the posterior superior aspect of the humerus is known as hill sac lesion. And on the X-ray you will see this defect here, and the Bankart lesion is seen on the glenoid in the anterior aspect whenever there is an anterior shoulder dislocation. So shoulder dislocation होगा तो bony Bankart यहाँ पे बनेगा glenoid पे, and hill sac यहाँ पर बनेगा. But if there is a posterior dislocation होगा तो the humerus will be here. So the reverse hill sac will be on the anterior aspect of the humerus, and the Bankart will be on the posterior aspect of the glenoid there. Right? So this is reverse bony Bankart and reverse hill sac seen in posterior dislocation. Posterior dislocation is not so common, तो क्वेश्चन नहीं आता है. Again on MRI, how does this hill sac lesion appear? This is how a hill sac lesion appears. This is the defect in the humerus. So H for humerus, H for Hill sac. Okay, so how to approach next 30 days? We'll take this question just in a bit. For radiology, if we revise this PDF, would it be enough? Yes, just revise this PDF, that is enough. चलो फटाफट radiograph shown of a 19-year-old male who is brought to the orthopedic OPD with complaints of pain in the right lower femur. What is the diagnosis? So let's see. So osteosarcoma हो सकता है क्या? पहली बात एक्सरे देख लेते हैं. So एक्सरे में क्या है? There is lytic lesion. So number one, there is lytic lesion. And does it look benign or malignant? So there is cortical breach. यहाँ पे cortical breach है. So this looks malignant. Right? So giant cell tumor is out, fibrous cortical defect is out. Now, difference is osteosarcoma or chondrosarcoma. Now, chondrosarcoma happens in elderly. And in chondrosarcoma, what do you get? You get C or O type calcifications, जिनको हम बोलते हैं ring and arc calcification. Now, osteosarcoma we will say कि sir osteosarcoma shows sunburst periosteal reaction or Codman type. So remember, 25% of osteosarcomas are purely lytic. Okay? So even if you don't know this fact, 25% of osteosarcs are purely lytic, you have to rule out options. So osteosarcoma happens in 10 to 20 years age group. Chondrosarcoma happens in elderly. Chondrosarcoma is not the answer. The answer is osteosarcoma, right? So you have to rule out options. Rule out options से ही निकलेगा आंसर. कितना भी पढ़ लो, rule out करके ही निकलेगा आंसर. So see, this is also an osteosarcoma. This is also an osteosarcoma. This is how a chondrosarcoma looks like. You see this ring and arc calcifications. Now this is how a fibrous cortical defect looks like. Although the name is cortical defect, but there is no cortical breach. ठीक है, cortical based tumor होता है, very well defined, very well localized and small in size. Cortical based tumor होता है, but there is no cortical breach. Unlike the name, cortex is intact. Now, what is the diagnosis in this 28-year-old lady whose HSG is shown below? So you are seeing what? This is an HSG, Leach-Wilkinson's cannula. You are seeing that only one side fallopian tube is opacified and it is patent. So the Q here is one fallopian tube, one side fallopian tube opacified. अगर एक ही साइड की opacified है मतलब एक ही fallopian tube है and it is a unicornuate uterus. It is a unicornuate uterus. Right? Sometimes what will happen? You will see the uterus like this, but two tubes will be coming from here. Right? That will be a normal uterus. Normal uterus will sometimes be very small, very thin, and look like and it will be looking like this. But you have to look at the tubes. Right? So let's label the other types also. So this is unicornuate uterus. This is two cervix and two uterus. So this is uterus diadelphus. This is bicornuate uterus, septate uterus, arcuate uterus, and this is T-shaped uterus, which is seen in death-related Mullerian anomaly. Right. So now I've kept few other important questions also. So let's see this question. A 38-year-old male gymnast was brought to the emergency after damaging his perineal area during practice. He is having difficulty to urinate. and a urological examination reveals blood at the tip of meatus, hallmark of a urethral injury. So blood at meatus equals urethral injury, as well as perineal hematoma. So we are talking about a urethral injury. Investigation of choice for urethral injury is RGU. What is the most likely site? So what are you seeing here? Tell me what is the most likely site here. This is an RGU, penile urethra, bulbar urethra, membranous, and prostate. What is the site of membranous? What is the site here? This is a membranous urethral injury, and most common site is also membranous urethra. Alright, now what is the name of the classification? The name of the classification is Goldman's classification. Goldman's classification of urethral injury. Chalo, one-liners, only questions, no discussion. Okay, these were PYQs. So I've kept these PYQs as it is. We'll do a rapid fire PYQ. Identify the structure marked in the CT scan shown below. What is this arrow pointing towards? We'll just do question and answer, no discussion. ठीक है, yes, the answer is SVC. This is SVC. मैंने बोला तो नहीं करूँगा, बट कोई नहीं, आदत से मजबूर है. Ascending aorta, descending aorta, main pulmonary artery, left pulmonary artery, right pulmonary artery. Chalo, next. X-ray of the skull as shown. What is the diagnosis? चलो, पेजेट्स लग रहा है, पेजेट्स तो बिल्कुल नहीं है. हाइपरथायरॉयडिज्म, थायरॉयडिज्म में तो कुछ मिलता ही नहीं है हमें. मल्टीपल माइलोमा एंड हाइपर पैराथायरॉयडिज्म में डाउट है. नाउ रिमेंबर, मल्टीपल माइलोमा यूजुअली बड़े होते हैं लीशंस, एंड हियर द लीशंस आर वेरी वेरी टाइनी टाइनी टाइनी. दिस इज व्हाट इज अ टिपिकल पेपर पॉट स्कल. द आंसर हियर इज हाइपर पैराथायरॉयडिज्म. पेपर पॉट स्कल. राइट, नाउ क्वेश्चन था अभी रिसेंटली INI में आया है, स्कल एक्सरे वाज गिवन and they were lytic lesions, and you were asked which thyroid cancer shows skull mets, and the options was follicular, papillary, Hürthle cell. Right, so follicular answer. Papillary shows lymph nodal mets. Chalo. Which dye is employed for identification of esophageal perforation during diagnosis? Esophageal perforation during diagnosis, which dye is employed? या फिर you can be asked Borha's syndrome. What is the investigation of choice? So whenever esophageal perforation has happened, or any bowel perforation has happened for that matter, what do you have to give? You have to give iohexol. So Borha's syndrome investigation of choice क्या होगा? It will be CECT with iodinated or water soluble iodinated oral contrast. Right, basically barium is contraindicated. This is a very important point. Any perforation, bowel perforation, esophageal perforation, stomach perforation, barium is contraindicated because it is water non-soluble. Now what is the diagnosis here? What is the arrow pointing? 50-year-old patient come with sudden onset chest pain and CT is shown. What is the diagnosis? So you are seeing that this is the descending aorta, this is the ascending aorta. ठीक है, ये SVC है हमारी. Ascending aorta में I am seeing a membrane. यहाँ पे भी हमें मेम्ब्रेन दिख रही है, यहाँ पे भी हमें मेम्ब्रेन दिख रही है. ग्रेट वेसल में मेम्ब्रेन दिख रही है, मतलब वो इंटिमल टियर, इट इज एन इंटिमल टियर. इंटिमल टियर मेक्स इट एन एओर्टिक डायसेक्शन. चलो, चाइल्ड प्रेजेंट्स विद लेफ्ट टू राइट शंट and a high output cardiac failure. The following is an MR angiogram. What is the diagnosis? Yes, you're right, Dr. Riluzol. It is a Stanford type A. Ascending aorta is involved. This is Stanford type A. So high output cardiac failure, left to right shunt. And what are you seeing on the MR angio of the brain? So on an MR angio, you are seeing that there is a dilated vein, dilated vessel, not vein, dilated vessel in the posterior fossa. So vessel एक ही malformation में होता है. Dandy Walker में क्या होता है? Dandy Walker has cystic dilatation of fourth ventricle. That is not there. There is no cyst. There is vessel. So Dandy Walker is out. Pneumocephalus will have what? Pneumocephalus will have air. Is this showing air? No. So pneumocephalus is out. A venous sinus thrombosis and vein of Galen malformation, both can be the answer because you are given an MR angio. So vessel दे रखी है. Now thrombosis में what you will see? You will see a filling defect. जब भी thrombosis होगा, you'll see a filling defect. What are you seeing here? A large vein in the posterior fossa. This is a malformation, and if it happens in a child, left to right shunt, a high cardiac output failure, the answer is a vein of Galen malformation. Vein of Galen malformation. Okay, so tension pneumocephalus, you're right. Mount Fuji sign. Mount Fuji sign was asked previously. Venous sinus thrombosis, again you're right. Empty delta sign. This is seen on CECT. CECT brain. This is a MR angio. Chalo, good guys, great. 55-year-old male patient presented with complaints of dyspnea and congestive heart failure. The clinician wants to know it's a heart failure with preserved ejection fraction or a reduced ejection fraction. Which of the below investigation is used to calculate the ejection fraction? So first of all, nuclear medicine scan is not used nowadays to calculate ejection fraction. But for the sake of this question, tell me which cardiac nuclear medicine scan is used to calculate ventricular volumes. So SPECT using thallium-201. Now this is used for myocardial perfusion. PET-CT is used for myocardial viability. And SESTA may be scanned with stress. This is also for perfusion. Only one scan is for volumes, that is Muga scan. Right? So ventricle volumes is by Muga scan. Muga की full form क्या है? मोगा नहीं है. मोगा पंजाब में एक सिटी है. Muga is multi-gated acquisition. Answer is Muga scan. Now, if you are asked for ejection fraction, best modality, and the options are echo, Muga scan, cardiac MRI, what will you answer? Best modality for ejection fraction for ventricle volumes, या आप क्वेश्चन में कभी कभी ये भी आ सकता है ventricular volumes. Best modality for ventricle volumes is, remember, cardiac MRI. It's not echo. No, it's not echocardiography. Best modality for ventricle volumes is cardiac MRI. Now, best modality for myocardial viability. Option: cardiac MRI, FDG PET, echo. What is the best modality for myocardial viability? For myocardial viability, best modality is FDG PET. It's not cardiac MRI. ठीक है, दोनों अलग अलग क्वेश्चंस हैं, अलग अलग पूछे गए हैं, अलग अलग पूछे जाएंगे, आंसर अलग अलग है. ठीक है. For ejection fraction, it is cardiac MR. For myocardial viability, it is FDG PET. So next question, what is the diagnosis of a 65-year-old male experiencing chronic neck pain and back stiffness? Sorry, neck stiffness and back pain. Based on the given X-ray, what is the diagnosis? So cervical spine जब भी X-ray दे रखा है ना, cervical spine में दो ही चीजें होती हैं, या तो आपको rheumatoid arthritis होता है या फिर आपको डिश होता है, ठीक है. So what do you see here? You see that there is this calcification along the anterior longitudinal ligament. So there is calcification along anterior longitudinal ligament. This is hallmark of dish. Dish stands for diffuse idiopathic skeletal hyperostosis. Candle dripping, ठीक है, candle wax dripping appearance. This is dish. So that's all, folks. So that's all for today's session of PYQs. Thank you so much for being so attentive, for being so responsive, and thank you so much for attending today's session. Now let me come back to a few more generalized topics of how to approach the next 30 days. So how to approach the next 30 days before NEET PG. So again, if you guys are new to the group, we have again Sankalp NEET PG INI-CET mentorship group on Telegram. This is free for all. I'll be taking a session today also for the students on the Sankalp NEET PG group regarding the next 30-day strategy. But as a whole, just keep the last 15 days separate for a theory revision. A good theory revision in the last 15 days, that is if the exam is on 3rd August, maybe from 18th July till 3rd August, just revise your important theory notes again and again, right? Because this last revision keeps everything fresh in your memory. What students usually do is that they keep practicing questions, but there are some important things in revision notes which are not covered in question. ठीक है, कुछ ऐसे topics होते हैं, कुछ ऐसे pointers होते हैं जो कि revision notes में दिए होते हैं. And if you just revise your revision notes in the last 15 days, believe me, your rank will really improve, because by now you must have read your revision notes multiple times. 5-6 बार पढ़ लिए होते हैं revision notes. So revise your all 19 revision notes in the last 15 days. That's my only advice. Now, any specific query if you have, please mention them. I'll be taking any specific queries if you have. Right now, what to do? So, Akhi is asking, sir, right now only questions. So, it depends. So, if you're fed up with theory, you don't want to do any theory, doing questions daily is fine. Giving GTs alternate days is fine. If you want to revise with the help of GTs, that is a good strategy, right? Retrograde revision. But do that only, if your baseline 140 correct in GT हो गया है, अगर baseline 140 correct हो गया है, 140 150 correct तक हो रहा है, then yes, revision by GT is a good strategy. But if you are at 110, 120, then giving more GT really does not help. Retrograde revision helps if your baseline knowledge is good, and baseline knowledge will fetch you around 140 questions correct. Sir, after PP the momentum is slower and GT scores are stagnant. What is PP? Postponement. अच्छा. After postponement, the momentum is slower and GT scores are stagnant. तो अभी मान लो मोमेंटम एक GT दो, GT में खराब स्कोर आएगा तो मोमेंटम बन जाएगा. तो the only way to improve a GT scores is to have a good revision of that GT. So when you are reviewing a GT, right? When you're reviewing a GT, you have to note down subject wise, or if your app gives a subject wise analysis ki out of the 20 questions in obs and gynae, how many you are getting correct. So I write a rule of there is a rule of 4, 3 and 2, right? So in subjects like obs gynae, surgery, medicine, PSM, your maximum incorrects can be 4. Now in subjects like path, pharma, micro, anat, biochem, physio, peds, your maximum incorrect can be 3. And in minor subjects, your maximum incorrect can be 2. Right? So this is the rule of 4, 3 and 2. If you have more incorrects than 4 in any of these major subjects, then that subject needs to be focused on. Right? This is an important rule, and I have seen that, with this rule, you will get around 150 corrects. 150 correct is a top 10,000 rank in NEET PG. So if any of these subjects has more than this number of incorrect questions in your GTs, that subject needs to be focused on, as simple as that, in the next 15 days. How many GTs should you write? It is totally up to you. There is no magic number that, okay, if you give 5 GTs or 10 GTs, you will now get a top 10,000 rank. And if you've only given 2 GTs in the next 30 days, you'll get a 50,000 rank. There is nothing like that. It is totally up to you. So if you're following a retrograde method of revision, you can increase your frequency. So if you're like revising with the help of GTs, you're giving GTs every 2 to 3 days to revise your syllabus. You don't want to pick up separate revision notes or BTR notebook for each subject, then give frequent GTs. But if you're revising from your notebook, or if you're revising with daily 100 questions, all mixed bag custom modules, then giving GT once per week or once 10 days is fine. Yes, these predictor GTs are free for all. And again, these are NEET PG based grant test based on made by physics wala meded, and they'll give you an all India rank as well. So it is a good idea to give this predictor GTs, because giving different platform GTs is really helpful. That removes the bias of the question bank, because most of the GTs by a particular platform is made by its own question bank, right? So giving multiple platform GTs really takes care of that bias. So in every incorrect MCQ feeling 20th copy become moti copy, that's fine. 20th notebook can become a moti copy, that's totally fine. कितनी information रखे सर, कोई बात नहीं. So that is why the last 15-day revision, the whole point of the last 15-day revision is you can't remember everything. So last 15-day revision is a very, very important concept, because we know that the information is endless and you can't remember everything. So you need to keep theory fresh in your memory so that you can vomit out on the next day. That is the basis of the last 15 days revision. So if you have a moti copy or a choti copy which has now become a moti copy, the exam is on August 3rd, right? So July 31, August 1st and August 2, you keep it for your choti copy which has now become a moti copy. And from, let's say, July 15 to July 30, you revise your RR notes of all 19 subjects. ठीक है Rahul? So Rahul, this was your query. This was the answer to your query. AI will replace radiologist job in the future? No. So guys, that's all. So I'll meet you on Telegram group. I'll have a Telegram live today at around 10:30. Earlier it was scheduled for 10, but let's keep it at 10:30 p.m. today. Okay, I'll meet you then. Right, there's a class from 9:30 onwards on the Telegram group of this Sankalp NEET PG, you can scan this QR code and join the Sankalp NEET PG group. I'll be going live there and answering all your queries there. Thank you, Gayatri. Thank you for that compliment. And thank you. I hope that I recover from this viral very soon. And I'll see you guys on Telegram group if some of you are joining there. Else, all the very best for the upcoming exam. Keep up the momentum. 30 days to go. And I hope that this is the last NEET PG that you guys sit for. Thank you and all the very best. Okay, I'll make a detailed video on that on my channel. Bye bye.